here, Ramsey Badawi, and other colleagues, actually, other co-PIs from the University of California in Davis. They got $16 million from the National Institutes of Health in the US, and they collaborated with a company based in Shanghai called the United Imaging to build the device that you see here. So basically, they increased the axial field of view so that you can start acquiring the data immediately after you inject the patients. And then you have a number of other companies and research groups suggesting other conceptual designs. So basically, we have Siemens with 106 centimeters axial field of view, right? And then you have another prototype from the University of Pennsylvania, which is not commercialized. And then you have General Electric and United Imaging Company with different design trends. So the advantage, as I mentioned, is that you can start by acquiring the data immediately after you inject the patients with these radiopharmaceuticals. And this technology actually exists around the world, so even in Algeria, so we have a number of PET scanners installed in the private sector and also in one major hospital in Algiers. Right, so you see basically after you inject the patient, you can get the information about what is taking place within the plasma, different compartments within the body. And then we can also generate this, in addition to the standardized uptake value image, which is basically the static scan. We have also information to the microparameters using kinetic modeling, so we can get information about some physiological parameters, which are extremely important actually either in clinical or research settings. So a number of years ago actually, so almost 2-3 decades, the scientists realized that we have a number of advantages if we combine the information that is gathered by anatomical and functional imaging modalities. And this scanner that you see here, actually, the idea was originates actually in our institution at the University Hospital of Geneva. A partial ring scanner was actually under maintenance, and then an oncologist entered into the room and suggested the idea of combining PET with X-ray CT. So the principle is that you have an X-ray CT in the front, right? There's X-ray tube on the top. You acquire what we call the scout scan, and then we start acquiring the spiral CT after we define the axial field of view. And then we have a single bed actually joining the two scanners. So basically move the patient from the X-ray detectors to the PET scanner. And then you acquire the PET scan, and then you fuse the images together to get the PET CT scan. And then this is what you present to the MDs for clinical diagnosis. Could be monitoring and treatment response or radiation therapy treatment planning. So the number of applications is really large. PET MRI is kind of the other side of the story, so it's exactly the same principle. Instead of combining PET with X-ray CT, we combine PET with magnetic resonance imaging, and then different design trends have emerged. For instance, Philips, we got the first whole-body PET MRI system installed in our institution in almost 15 years ago. So it's kind of a la PET CT design, right? So we start with MRI, and then you rotate the socle, then you push the patient towards the PET detectors to acquire the PET data, and then you fuse the two images together. So this is kind of sequential acquisition, so one after the other, and then you see that the Siemens, General Electric, and United Imaging, they have devised these solid-state detectors, which are MR compatible, just to avoid the interference between the two subsystems, and designed fully compatible systems that can acquire the data simultaneously. Just to show you some images actually from clinical settings, so you have a two-weighted MR, and then the PET image, and then the fused image on the right, and then gated cardiovascular imaging, where you see the MRI, you see the PETs, and then the gated PET MRI. What is now emerging in the field of medical image analysis, what I showed you is basically the basic principles, and then the apparatus or the devices that we use in the clinic. Now, on the image processing, image analysis side, so there is an interest actually to move from qualitative assessment, because basically the MDs, they are trained actually to interpret the images, and they can distinguish between normal distribution of the tracer within the patient's body and then some kind of abnormal distribution, right? So this is how they are trained. And then on top of that, they use some very simple metrics to guide them in clinical diagnosis and especially in monitoring treatment response. For instance, what they can do is that they take, this is one small number of pixels actually within malignant disease that you see here, where we have a high uptake of the radio tracer. And then they take the hot pixel within this volume. This is what is called the standardized uptake value max. And then if the patient comes from baseline scan, and then he is going to undergo chemotherapy, radiotherapy, or a combination of the two, and then he will come again to the same department for the follow-up scan to see if the patient is responding to their therapy. And then to see if the patient is responding to the therapy, they look to the curves that you see on the right side there. So if the metabolic uptake within the lesion is decreasing, this means that the patient is responding to the therapy. If it's not the case, which is the case unfortunately for the second patient, which died after a few weeks, so they know that the patient is not responding to the therapy, and unfortunately for him, the patient died a few weeks later. So the idea is to move from this qualitative interpretation, from this simple SUV matrix, where you basically look only to one pixel and discard the whole information that you have, to interpreting the whole image as such. And we know that the images are not only pictures, they are data. So we have the option actually to look at a number of features after we segment what we call the gross tumor volume. Basically, we apply some segmentation techniques to gather the contours surrounding basically the malignant disease. And then we can extract information about intensities, could be a histogram or any other intensity-based metrics, could gather information about the shape of the tumors, and then we know that the shape is extremely important actually in terms of prognosis. And then we can also extract the heraldic features, so the texture features, and build the heat maps that you see on the right side. And I'm going to show you some examples actually at the end of this presentation. Because this is an AI meeting, I think I'm going to just skip the history of AI, because most of the attendees actually, they are familiar with what Turing did in the 50s, and then the famous 1956 Dartmouth conference, which took place in the US, and with the birth of AI by the fathers, Minsky and McCartney. And then what is important in the slide is that the development or the history of AI is nicely correlated with history that we have in medical imaging and medical physics, starting from the use of the Linux in the 50s, Stanford University, till the advent of positional emission tomography, large axial field of view, and then the combination of PET with the Linux, something that you see on the right side. So it's not really surprising that the Royal Swedish Academy of Sciences has decided to award the 2024 Nobel Prize in Physics to John Hopfield and Geoffrey Hinton for foundational discoveries and inventions that enable machine learning with artificial neural networks. Now, why do we need actually medical AI in medical imaging? We're likely to see that many operator-dependent tasks will become increasingly automated to address basically staff shortages. And they limited actually this argument with only one study published in the UK in 2019, where they looked actually to the shortage in terms of qualified consultants in radiology compared to the demand. You see that they had 33 in 2019. They expected this to increase to 43% in 2024. Most recent report actually they demonstrated that this gap is not as dramatic as they expected, as they forecasted, but still only in the UK, so it's between 20-something till 40% in terms of shortage. So how to close the gap? I think we increasingly automated diagnosis of routine cases will be supported by clinical support decision support systems. And this is already taking place in mammography, for instance, where the radiologists are supported by clinical support systems. And then the radiologists are going to focus only on the most difficult cases. And we believe also that the radiologists will not only provide reports, but they will be involved in the decision-making process. I just looked into this morning, actually, when I looked into the slides, updated this slide. If you look to the number of requests to the Food and Drug Administration, which is the regulatory body in the US, in Europe we have another organization actually looking to the approval of these devices. You can see actually two major observations from this slide. The first is the exponential increase. They're really flooded with a large number of requests from industry, from academic groups, by these AI-based devices and algorithms. And the second observation, what you see on the right side, is that the majority of those devices and algorithms are in the field of radiology, medical imaging, followed by cardiology, and then internal medicine. And this is just to show you one example from a recent paper published in the Journal of Nuclear Medicine. A patient, so 43-year-old man, having a glioma. And then the radiologist depicted basically one malignant disease, which you can see actually on the MRI image, and again on the PET image that you see on the in the last row in the bottom here. So this is a tracer called fluoroethyltyrosine, which is an amino acid with a high uptake in the glioma, which is kind of brain tumors, right? So the MDs have seen only one malignant lesion that you see here. And then they use these images as input to an AI-based software, which segments basically the malignant disease. And this AI-based segmentation tool identified the second malignant disease in the hypothalamus, on the left thalamus, which was not actually depicted by the radiologist. And then the follow-up scan, which means 4 months later, the patients came again for an MRI in PENS, and the malignant lesion basically grow up, and then it can be easily seen on the MRI and also on the PET image. So we feel that these AI-based solutions are not going to replace the radiologists, but they can provide them with some additional information that they might miss during clinical diagnosis. I was also part of a large task group in Europe within the European Federation of Organizations of Medical Physics, where we basically looked into the program or the curriculum for clinical medical physicists and also for postgraduate students, so PhD students basically, and then we came up with an update, major updates, because we feel that AI is not going to be limited to industry and to academia, but it will have a deep impact on our profession as medical physicists and also on the radiologists and nuclear medicine physicians. So this is in Europe, and then we have the same discussions taking place in the US and in Oceania, in Australia and New Zealand. So now if we start to illustrate actually the different applications of AI in medical imaging, try to cover this within the next 10 or 15 minutes. So AI is used basically in the whole chain of medical imaging, starting from data acquisition to image display processing, the generation of automated reports, the quantification and automated lesion segmentation and image analysis. And let's start from the hardware application. So one of my PhD students called Amir, we developed actually a number of years ago, so this small animal system that you see on the left side here. So this is a PET scanner dedicated for small animal imaging, basically rodents, rats and mice. And the majority of the scanners used in preclinical devices or clinical imaging systems use the pixelated crystals that you see here. So this means that you have a certain size of scintillation crystal, which is called cut in small pieces, right? And then there is an interest to move towards what we call monolithic crystals, which have a higher spatial resolution, high sensitivity. So we decided actually to see what would be the improvements in the performance of the imaging device that you see here if we change the design, the conceptual design from pixelated crystals to monolithic crystals. And then we trained the MLP, multi-layer perceptron, using Monte Carlo simulation, which served basically as a standard for data generation. And then taking you directly to the results, you see that we have major improvements in spatial resolution, both in the axial and in the radial direction compared to what we call the Anger logic, which calculates basically the centroid within the scintillation crystal. And you see that the improvement is from 20 to 27%. 3 minutes, all right. So the second application, very quickly. So we have some additional illustrations here, but I'll try just to save some time. You see the point sources, you have much improved spatial resolutions. The second application still for hardware development is that one of the scanner manufacturers that I'm not going to name here decided to move from LYSO crystals. So this is a very fast scintillation crystals that enable to gather information about the time of light, because the two-annihilation photons travel at the speed of light, right? And then they decided to go for less expensive scintillation crystal, which called BGO. So we are missing what we call the time of light information, and then we decided to train a neural network to be able to synthesize artificially the time of flight images from the non-time of flight images And then we trained the data both in the image space and in the sonogram space. Again, for the sake of time, just to show you the outcome, if I zoom through the images to basically see some improvement, I'm not sure that you see the PowerPoint slide, but if you look to the images on the high resolution console, I can ensure that you see major improvements in spatial resolution for the AI-generated data sets. Going back actually to X-ray computed tomography, this is some other work actually by Yazdan, PhD students in my lab. So very busy slide, and the idea here is to try to limit the overscanning that we have inherently in X-ray computed tomography, because the technologists, in French they call them the manipulateurs or techniciens en radiologie médicale. What they do actually is that they try to increase the actual field of view to be confident that the radiologist is not going to miss anything. And obviously this is going to increase the radiation dose to the patient. So the idea here is to artificially generate scout scans in the lateral and in the anterior or posterior direction. And then we have a neural network trained to segment the lungs. And then the idea is to limit the axial field of view to the thorax where we have the lungs only. And then you can see the results here. Basically, we saved the radiation dose, the effective radiation dose by 2 millisieverts, which is really substantial. And then the radiation dose to the thyroid, because of the increase in the axial field of view, is almost 67%, and then 99% in the anterior, in the superior direction, and 95% in the inferior direction. Another idea actually to decrease the radiation dose to the patient is to use what we call sparse view CT reconstruction. So the idea here is, instead of using the full number of projections, which is in the range of 2048, we use only one projection every 6 projections, and by this we reduce the radiation dose by a factor of 6. And then we have a complex neural network that I'm not going to explain here to reduce the radiation dose to the patients, ending up with the images that you see here. So this is basically the outcome of ours is the sparse view CT reconstruction. The reference is what you see on the right side, and then some other techniques are reported on the left side here. So we have a nice tool actually developed by Siemens to generate CT at different dose levels. So the standard one is the 100% that you see in the bottom on the right side, and then we can generate 20%, 1%. I'm going to stop just in a minute, right? That's okay, go ahead. It's all right? And then just to show you that we can actually reduce the radiation dose to the patients by training a neural network which is going to generate standard dose images from extremely very low dose images that you see here. So the standard dose image is shown basically in the middle. The low dose image is what was generated from this image that you see on the left side. And then the standard dose image by factor 30 reduction is what you see on the right side. So just for the sake of time, we can do the same actually for position emission tomography to reduce the radiation dose to the patients. We can do also the same for magnetic resonance imaging. There is no radiation dose, but we decrease the acquisition time by a significant factor of 20, which is the case here. And this is extremely important, especially for the comfort of the patient, because the patients tend to move, right? If they have Parkinson, if they have any neurodegenerative disease, they get to move. We have some susceptibility artifacts which occur also frequently that can be dealt with efficiently with the AI-based solutions. We develop also automated segmentation tools to develop with the models that you see here, especially for pregnant patients. This is extremely important actually in clinical setting, because we need to estimate the radiation dose delivered to the fetus following an abdominal CT scan. And then Tian Wu used some unit network to be able to automate the segmentation procedure. As you can see here, very good agreements between the two images. We are still working on the segmentation to improve the Dice coefficients, considering also the pediatric patients, and a number of other projects that I'm just going to skip here, just to show you another example actually, which is extremely important in my opinion, is outcome prediction. So outcome prediction, basically using this, what I call radiomics, is a very hot topic. And the idea is basically to segment the malignant lesions, to extract the texture features, and turn them to apply some deep learning model to be able to predict the outcome of the patients. So what Yazdan from my group did here is that they extended this analysis not only within the GTV, within the gross thermal volume, but also to the normal organs, such as the heart, the lungs, and so on. And then he looked basically to different metrics to be able to generate actually what we call the concordance index. And then the conclusion of this work is that the outcome prediction using the GTV, which is extended actually beyond the malignant disease, is going to improve the prognosis and the outcome prediction. Right, so with this, I think I'm just going to conclude, and then, yeah, the federated learning, I think, is extremely important, especially in the health sector, because of privacy issues, ethics, and so on. And just as conclusion, I think we are far away from the predictions made by these two famous people that you obviously know. So we still don't have self-driving cars. And the radiology as a profession still exists because Geoffrey Histon predicted that radiology is going to disappear because AI is going to replace the radiologist. And I think a nice prediction is that, well, machine learning is probably works very well, but we don't know well. We don't know why it works so well. So the major challenge for mathematicians and physicists is to understand how it works and why it's working so well. And I think this is one of the major challenges that we're going to face within the next few years. And with this, I just thank the funding bodies actually funding our research and my team actually doing the work that I presented here. And then thank you very much for your attention. Happy to answer questions.
Thanks, Professor Habib, for this excellent presentation.
Yeah, you can ask your questions in English, in French, or in Arabic. Yeah, just feel free. Yeah.
So we made it easy for you. You can ask your question in Arabic, French, English. Please.